Thanks very much. I'd like to welcome everyone to our first event in our series on COVID-19 and global development. And today we're exploring what COVID will potentially mean for the world's most vulnerable citizens. And our speakers come from a range of backgrounds, from academia to the humanitarian sector. I'm sure you're very keen on what they have to say, so I'll keep my comments very brief. Crisis and disasters are no stranger to the world's poor, from drought to famine to epidemic diseases. And these disasters for the lucky citizens of the global north tend to play out on our television screens. And what's different about COVID is this disaster is ours. And countries with relatively robust economies and strong healthcare systems are now in crisis. And of course, we don't know how this is going to play out in the endemic regions of the world. But from 2008, we really have a much clearer idea of what happens when the global economy crashes and what impact this has on endemic countries and their poor citizens in particular. We also know from past epidemics that showed us the issues that countries face when weak and fragile healthcare systems come under stress. And currently there's a lot of rhetoric in the news and discourse about how COVID is the great equalizer and it knows no boundaries or distinction and, between the rich and the poor. And of course, that's just utter nonsense. Virtually all of the advice to prevent COVID, from hand washing to social distancing to working from home, is absolutely impossible for what is pejoratively termed the bottom billion, or the world's least well-off citizens. And there's a real risk that COVID will just simply accelerate global inequalities, and it'll be business as usual. But on a really more positive note, what we're starting to see, there's global practitioners, global development practitioners are starting to talk about this new manifesto for sustainability post-COVID. And I think that's a really, really positive thing. And I think, the time is now to address some of these inequalities of the past 50 years of global development haven't addressed. So I'm delighted to welcome our first speaker, Professor Hannah Kuper. She is the director of the International Center for Evidence and Disability at London School of Hygiene and Tropical Medicine. She is our resident expert on the study of disability in low and middle income countries. And one of her key research interests is in the relationship between poverty and disability and the role of social protection in breaking this cycle. So welcome, Hannah, and thank you so much for joining us today.
Well, thank you very much for having me. And I see on the list that there are friends and colleagues and brother-in-laws on the webinar participants. So hello, and I look forward to the day when we can all meet in person. I'm going to try and share my screen. So to get my PowerPoint rather than my emails. Can everybody see this now? Yeah? Okay, great. So thank you for the introduction. So as Claire said, I'm going to be talking about COVID-19 in relation to disability. And I'm going to talk from the perspective of the International Center for Evidence in Disability, but also describe some of the activities that we're going to try and do in this space from the DFID-funded PENDA program. So the coronavirus is affecting everybody. It's affecting, as Claire said, high income, low income countries, everybody in the most extraordinary way. And within that, why is it important, or why do I think it's important to try and focus on specific groups, given that we are also very affected? And the question that I'm posing today is, why should we include disabled people within the COVID-19 response? And what's quite interesting is we started to think about this question about 3 or 4 weeks ago within the context of the UK and what was happening. And we're now relating those experiences and thoughts to other settings. So I'm going to try and make the argument as to why we might want to think about including people with disabilities in COVID response, and then also to start thinking more practically about what that means and how we would do it. So, what do we know about COVID? Well, we know that it doesn't affect everybody in the same way, and that the death rate varies enormously by age and by health status. So in this graph, this is data from China, but it's being replicated around the world. We can see that the people who are the most vulnerable to dying are older people, so certainly people 80 plus, but also 70 and above, 60 and above, and people with pre-existing health conditions. And so there's quite a simple argument for why within this context we should also focus on disabled people. So the first is that there are about 1 billion people with disabilities globally, as estimated by the WHO. And like everybody else, they're all at risk of COVID-19. But actually within that, even though that's an enormous group, people with disabilities are at even more heightened risk. So first of all, if you look at the group who are over 60 years old, who are the group most likely to die from COVID, 1 in 3 are disabled, as estimated by the WHO. And if we look by health condition, so people who are particularly vulnerable, those with cardiovascular disease, diabetes, respiratory disease, hypertension, and we all also know that disabled people are at about twice as likely to have those conditions as people without disabilities. So within a context of the world being at risk, actually people with disabilities are 1 billion people, and they're likely to be at much greater risk of dying from COVID. So it's really important to consider them within the COVID response. But then we need to think practically as to how to include disabled people in the COVID response. And here is another reason why we should focus on this group, is because there are additional difficulties. So it doesn't mean that we should offer the same things to people with disabilities as everyone else. They must be included in the mainstream, but there might also need to be additional targeted interventions directed at disabled people because of the additional issues that they face. So for instance, the WHO, DFID, the UK, they're very commonly promoted mitigation strategies to stop people getting COVID-19. So these fall into kind of 3 main camps. So the one is hand washing, and UK has just announced that they're going to target 1 billion people with a global hand washing campaign, social distancing, and staying at home. And what we know is that disabled people will face challenges in all of these aspects. So people with disabilities have got less good access to hygiene facilities. They may find it more difficult to access mainstream services. And if people are reliant on carers for their, people with disabilities are reliant on carers in their day-to-day life, social distancing is going to be very difficult, and staying at home may be very challenging if people need support of others. So these mitigation strategies may not always be appropriate in the same way for people with disabilities. The second issue is that some people with certain impairments may find it difficult to receive that information. So how do we get that information about what we should be doing about COVID? We get it through talking, we get it through information on the internet. But if you have a hearing impairment or an intellectual impairment or a vision impairment, it may be more difficult to get that information. And so you may not know as well what should be done in terms of mitigation. So here again, we might need to think of additional things to do. So for instance, the NHS has been giving additional information in easy read formats or in sign language for people with different types of impairment. So that's to kind of prevent people getting COVID in the first place. But then once people get COVID, there again may be specific vulnerabilities of people with disabilities. So the picture on the left is of people with dementia in a home in the UK and the kinds of social distancing that's being implemented. But imagine if one of these people develops COVID and has to have complex treatment or is separated from their support network. How is it going to be explained to them why loved ones can't come to see them or what's happening to them? And do the doctors and nurses have those skills? And if we get into very difficult situations where there has to be rationing of ventilators and so on, will there be discrimination against people with disabilities, even if their chance of survival may be the same, which would be a violation of rights? And we're certainly seeing that as a potential in the United States. So disabled people may receive poorer quality treatment if they do contract COVID. But these aspects are really kind of early on in the COVID response and a little bit where we are now. So this was a graph that was put on Twitter actually. And so in a way where we are with COVID is thinking about the first wave of response, thinking about mortality and morbidity at the moment. And now within the UK, we're starting to see a second wave where people are dying because they're not receiving the A&E care or they're not going for cancer treatment. But there's going to be a third wave, particularly affecting people with disabilities, where there might be an impact on the kind of care for their routine healthcare needs. And then ultimately there's going to be this fourth wave where there might be mental illness and economic impacts. So I'm going to turn a little bit from focusing on this first wave of the COVID response to what might be coming. So the first is this continuity of care. So people with disabilities, by definition, will have an impairment and often underlying health condition. So people may have a mental health condition or a physical impairment and therefore require care, and that care may be interrupted so that people's conditions may actually worsen at this time. The kinds of normal day-to-day care that we are all needing at the moment may be more challenging for disabled people. So in the UK, there's evidence that people with disabilities are finding it much more difficult to stockpile and panic buy, or even just get normal food deliveries at the moment, because it's more difficult for them to access it. And then finally, if people with disabilities are reliant on carers and those carers themselves get sick or stop coming, that can be extremely dangerous. As we've seen in Spain, where the Spanish army found a care home of residents dead and abandoned after the carers left. And there are examples of this happening in New York at the moment too. And again, there's some practical things that can be done. So lots of the supermarkets are prioritizing disabled people for slots, and there's some health services that can be moved online. So in China, mental health services were moved online during the COVID-19 outbreak. So some lessons to be learned also for low and middle income countries. So the ongoing needs must be met even in the midst of that epidemic. One of the issues at the moment that we're facing is that there's been apparently little disability inclusive data collection and planning. And so the world is a little bit in panic mode, and there's not been much focus on the specific additional needs of people with disabilities, nor how they can be included. There's some exceptions. I don't know if anybody's signed up to this COVID symptom tracker to report your daily symptoms. And they do have some measures of people with physical impairments, but not mental health conditions, vision or hearing. And what we're recommending is two things. So the one is in the middle, there's a picture of my colleague, Tom Shakespeare, and he's going to be leading a big initiative from our group to do qualitative research with people with disabilities in 6 to 7 countries to understand what their issues are in both the mitigation and the long-term responses of the pandemic in order to try and better meet their needs. And we're also advocating that questions on disability are included in surveys so that we can start seeing the additional vulnerabilities of people with disabilities. And we're working with a group in Bangladesh on that at the moment. And this is really important because what isn't counted doesn't count. So we're really putting emphasis on collecting data on disability, but also on disability inclusive planning, so that people working in COVID start to consult with people with disabilities in planning what needs to be done. And finally, I'm going to look at the aftermath. So what we know is that people with disabilities on average are poorer, and they also incur more costs in their day-to-day life. And there is likely to be extreme economic shocks as an aftermath of the pandemic, and this might affect the poorest and most vulnerable the most. So poor people are likely to become poorer, and we need to take that into account. So what might be needed is things like targeted social protection or livelihood schemes after the pandemic that specifically include people with disabilities, with the assumption that these inequalities will become greater, as well as at the moment, perhaps famine relief or economic packages to allow people to survive during this lockdown period. And we're going to be working with different agencies to do a process evaluation as to how far this works and what we recommend in terms of the inclusion of people with disabilities in these COVID responses. So I'm going to finish there. There are some details here, but I also just want to flag that a lot of the work that we're going to be doing in COVID around disability is under this PENDA program. And just to say, we're going to be doing 4 different things. So the work we're led by Tom Shakespeare to document the qualitative narratives of people with disabilities. We're going to work to looking at process evaluations and potentially impact evaluations of a disability inclusive COVID response. And we're going to be working on rapid reviews on different aspects, things like inclusive wash or inclusive social protection, which will make publicly available to help to try and inform this COVID response, to help make sure that people with disabilities aren't left behind. Thanks very much.
Hannah, thank you very much for that. That was fascinating, and I'm sure there'll be a lot of questions after. So our next speaker is Marcus Geiser, and he is a senior humanitarian policy advisor at the International Committee of the Red Cross. He joined the ICRC in 1999 and has managed field operations in Myanmar, Thailand, Libya, Darfur, and the DRC. From 2013 till 2018, he was the deputy head of the division working on humanitarian policy and multilateral diplomacy in Geneva at ICRC's headquarters. And now he's based in the UK. And he is the Senior Humanitarian Affairs and Policy Advisor for the ICRC. So Marcus, thank you very much for joining us today.
First of all, thank you very much for this kind invitation. And let me start immediately with a first answer to the question, are we leaving the poorest and most vulnerable behind? Well, yes, the risk is there, absolutely. I would say our COVID-19 response is going to be what I would like to call an endurance test for principles of humanity and impartiality. The floor through which humanitarians, as ours, should never fall. That's what we usually say. I will say a few words about what I would call the double vulnerability of conflict and COVID-19. I will then explain in a few words our approach and how we as an organization prepare ourselves for a marathon and not a sprint. I will then indeed focus on two vulnerable populations, detainees and IDPs, and if I can manage it, technically speaking, I will show you a short video how we approach this particular issue in Al-Hol camp in northeast Syria. The double vulnerability of conflict and COVID-19. Well, it is very obvious that even as the COVID-19 pandemic brings daily life to a standstill in many parts of the world, armed conflict and other situations of violence, of course, continue and will make vulnerable populations even more vulnerable. COVID-19 doesn't know any borders, conflict doesn't know any borders, and this combination can have this devastating effect of what I call the double vulnerability of conflict and COVID-19. The ICRC, of course, works in parts of the world where conflict and other violence have severely compromised society, yes. Sometimes not completely devastated, sometimes yes. Health systems and other vital infrastructures delivering essential services and preserving people's well-being are hugely curtailed. It is correct that if you look at the figures now, armed conflicts have not yet really been touched by COVID, yes, but we have countries, so for example, Yemen, Afghanistan, the DRC, where it seems to start. That's to keep in mind. Now, for people already living with volatile security conditions, the spread of the disease poses an additional threat of their lives. Violence-affected people may find it very difficult to prioritize preparedness, preventive measures against sickness as they contend and have to manage daily and immediate other threats to their service, to their safety, and have, of course, the struggle to meet their basic needs. And now there is another problem called COVID-19 on top of that list. A health system weakened by violence lacks the capacity to detect, manage, and also follow up cases of illness, including COVID-19, of course, which in turn increases, for example, the risk of transmission. And governments in countries affected by fragility, conflict, and violence are, generally speaking, I would say, purely equipped to adequately address the health, economic, and social toll of the pandemic, which places yet another layer of pressure on these already stressed systems under stress. So the development gains that some of these countries have actually made in recent years could be lost easily and fast. Development reversals are unfortunately likely and could become exponential without preventive action. Now, let me talk about our approach, and I kind of try to summarize it as we are preparing ourselves for a marathon and not a sprint. As a humanitarian, I'm of course a realist about today's challenges, but I'm also hopeful for the future. So I would actually say that COVID-19, may sound a bit strange now, does not necessarily have to be catastrophic for all war-torn countries and societies with weakened healthcare systems, etc. Plans to prevent and respond to the virus must urgently move forward before it actually gains a foothold in conflict zones. Prevention, I think, is the key word here. collectively, we have a body of experience, expertise in dealing with outbreaks such as this. We have a global footprint to go to the world remotest and neediest of places. And really collectively, not just the ICRC, but all of us who actually sit and join this call today. Now, what is to be done first? Of course, responding to the immediate needs, and I will talk about that when I talk about IDPs and the places of detention. At the same time, I would say it is absolutely critical to main services and humanitarian responses that are not directly related to the pandemic, but that also save lives, safeguard people's dignity and well-being, and ensure that vulnerable individuals and groups are not left behind in extreme poverty. Sustaining these essential services, emergency surgical care, maternal and childhood care, etc., builds people's resilience amid the crisis. This may help to preserve the fragile development gains in those fragile countries. Now, that is responding to the cumulative impact of COVID-19. In other words, COVID-19 is a crisis that suddenly emerged, but I think it has all the hallmarks of what I would call a protracted crisis, long-standing, intractable, affecting many facets of people's life, but also dynamic, yes, with moments of relief and sudden setback. It is a protracted crisis, not just an emergency that comes and goes. Helping conflict-affected countries deal with the intersecting effects of violence, poverty, natural disasters, climate shocks, and now COVID-19 requires partnerships amid governments, development actors, humanitarian organizations like the Red Cross and Red Crescent movement, and first and foremost, of course, with the people affected by conflict. Now, our approach, very briefly, is a multidisciplinary expertise. Yes, we have design, planning, implementing short-term emergency interventions, but while it's also simultaneously working on these resilience-building sort of activities. We, of course, mobilize we are part of the Red Cross and Red Crescent movement, our movement partners, yes. This is kind of a unique formula, I would say, of complementarity between local, national, regional, and international bodies. For its response to COVID-19 in conflict-affected areas, the ICRC has kind of delineated 4 following priorities, and there are many others, but we have to make some priorities. First of all, enabling vital health infrastructure to prepare and respond to crisis. Preventing the spread of disease in places of detention, again, prevention here as much as we can. Ensuring communities access to clean water. And sustaining activities that promote people's resilience. That's the more long-term stuff, if you like. Now, let me conclude with a brief focus on vulnerable populations, because this is also what we want to talk about. We've already heard about disabled people. I would now like to talk about detainees and IDPs very briefly. Now, with regards to detainees, it is a kind of a no-brainer that an outbreak of COVID-19 in places of detention could have devastating effects on the incarcerated population and as well the managing staff, especially in overcrowded prisons that we see far too often, where general health conditions are already poor and where proper sanitation and ventilation is often lacking. There is therefore an urgent need to prevent the entry and spread of infections in prisons. Now, we know from experience in other outbreaks like Ebola, for example, that improving access to water, setting up of hand washing stations can actually prevent disease spread in and outside of these detention facilities. So yes, it actually did work quite well in Liberia. Again, Liberia, Ebola is not COVID-19, a global crisis. We understand that. The ICRC works together with relevant authorities to strengthen standard practices such as medical screening of new arrivals, of detainees, the setting up of prevention measures, hand washing stations for detainees, visitors, guards, and delivery personnel. We also support disinfection measures such as fumigation campaigns, distribute soap and other hygiene and cleaning materials to detainees. And concretely, we do this, for example, today in Iraq, yes, in the various places of detention that we visit there. Covers currently a detention population of about 45,000 people, so it is a lot. Similar things go on in Afghanistan, for example, where we focus on 4 general hospitals in all over Afghanistan. Again, also this sort of raising awareness campaigns. Also control and training actually people on hygiene, not only detainees, but of course also the staff. It's very important. And similar activities go on in Ethiopia, we also, for example, provide soap to detainees. Yes, so each approach is a little bit different, but the main idea is here, really try to prevent disease from getting actually into those places of detention. So it's relatively simple measures. They can actually work, but not always, of course, yes. I'm not saying that this is the golden formula for everything, but this is at least what it is possible right now. Now, let me finish with IDPs. Of course, they have particular vulnerabilities, which we need to address. IDPs can either live in camps or in other sort of collective sites, yes, very often in informal settlements, in slums, in densely populated urban areas. And of course, they are particularly exposed to COVID-19. They are more susceptible to die in case of a complication if they get infected, yes. Again, the problem of overcrowding, poor nutritional status, health status, low sanitation, lack of hygiene, general barriers even to access healthcare are particular issues that need to be addressed. IDPs can also be and probably will be disproportionately impacted by the economic repercussions of lockdown, yes, measures, given the already precarious circumstances and heavy dependency on external support from host communities and humanitarian actors. There's also a risk of being stigmatized, yes, of IDPs are being stigmatized, being subjected to violent acts, yes. They may be seen by some, depending on the context, as being the one who brought the virus, yes, because they are a stigmatized population. They are some kind of foreign, yes. And last but certainly not least, authorities may also use COVID-19 sort of emergency as an opportunity to add and create further restrictions, legal restrictions, I mean, against IDPs who actually already face a particular problem of stigma due to their ethnic, religious, and political affiliation. Now, I try now to bring a short video clip, really just a few seconds, just showing how we operate in the Al-Hol camp, which of course all of you know, it's in northeastern Syria. It's a particularly vulnerable population because it hosts a population that not many people like, mainly families from so-called foreign fighters, yes. And now I see whether I can do that. I hope so. If not, I don't want to waste any space, any time. Let me just see. Share screen. Okay. No, where am I here? I think I'll probably leave that here. I don't want to waste time. I'm sorry about that. I can do that maybe later on. I think for some reason I can't make that happening. I see all kinds of screens here, but not necessarily mine. So thank you very much and look forward to a very interesting conversation.
Thank you very much for that, Marcus. And don't worry, we can work out a way to show your video after, because I'm sure it'll be really fascinating. So thanks very much for your insights. That was really interesting. So our next speaker is Karen Simons, and she's a Gender and Emergencies Advisor at Plan International UK. And her work focuses on the rights, needs, and capacities, on girls' rights, needs, and capacities during humanitarian crises. She's currently worked with, she previously worked with the Rohingyas in Bangladesh. She's worked on the Syrian conflict, Lake Chad crisis, and many others. Now her focus is on COVID-19. So welcome, Karen.
Thank you so much. I'm just sharing my screen. Can you see it? Great. Great. So good afternoon, everyone. Today I'm going to be talking about why taking into account the specific needs of women and girls is such a crucial aspect of any approach to this crisis, but particularly one in which we don't want to do any further harm. So Plan International's experience in emergencies has taught us that disasters are profoundly discriminatory. Whether they are human-induced or from natural hazards, they exacerbate the existing gender inequalities and vulnerabilities. And I thought a very pertinent example of that relevant to this crisis is from the Ebola humanitarian response, where we know that 60% of the mortality in Sierra Leone and 75% in Liberia was made up of women. So As Claire said earlier, this is not the great equalizer. It does not affect everyone differently. And this higher mortality rate there was directly related to the gendered roles and responsibilities that women and girls shoulder, particularly related to caregiving of the sick, elderly, the children, and customary practices where women would wash and prepare bodies for burial, which increase their susceptibility. So we think that a rights-based approach is critical to understanding this crisis due to the way that some governments are reacting, which can have severe impact on the realization of human rights. And as a girls' rights and humanitarian organization, Plan International has the responsibility to ensure humanitarian and human rights principles, and that our commitment to gender equality and inclusion must underpin our approach. So I'm going to take you through a few of the ways in which this gendered impact analysis has led us to consider. Firstly, in terms of the primary impacts, primary meaning the direct impact of the disease itself, we need to consider how gender roles might increase exposure to infectious agents. And here at this point, maybe I might pause and say that although we know that this crisis is affecting those with underlying health conditions, the elderly, far greater than young people, there are specific ways in which it is affecting young people and girls and women, and that's what I'm talking about. So in particular, thinking about underlying health conditions, we know that this is an increased risk for coronavirus, for people with coronavirus. HIV, which is a immunosuppressed syndrome, is of key concern. And of all HIV infections occurring among adolescents in sub-Saharan Africa, 80% are in girls aged 15 to 19 years. Adolescent girls and young women are also twice as likely to be living with HIV than young men of the same age. We know that this is a respiratory infection, and in many places where cooking is mainly done by women and girls using gas stoves, using firewood indoors, that contribution to indoor pollution may increase their susceptibility. We also, again, we know this from evidence from our programming, that there's a higher rate of malnutrition amongst girls, and that's because of preferential feeding habits where resources are scarce. And we know that access to healthcare can be restricted either because it's inadequate, because women and girls need permission of a male relative to access it, or because the service delivery itself is just not responsive to their needs. The secondary impacts, and here I want to stress that secondary means that they're indirectly caused by our reaction to the COVID-19 pandemic, and not that they are of secondary consideration, quite the opposite, in fact. So of key concern to us is the increase in gender-based violence. The implications of quarantine or home isolation can increase tensions in the home, which may in turn increase the likelihood of intimate partner violence and violence towards children. Survivors of this violence may need life-saving health and protection services, which will have decreased availability at this time as providers and resources are diverted elsewhere. Children face additional protection risks. When schools are closed, girls may be less able to access health, hygiene, and protection messaging. Their caregiving burdens may increase. And the economic impact of public health emergencies may force families to take their children, particularly their daughters, out of school to work, potentially leading to transactional sex or child early forced marriages, forced labor and child labor for boys. The increase in state powers of surveillance and increased military presence could lead to abuses of power and increased threats of sexual violence, fear and trauma. And we also know that in many of the places that we work, women and girls are responsible for collecting water. And due to the increased needs at this time for water, for hand washing, and also due to climate change, they have to walk further and further to do this, and there's a direct link between this and exposure to gender-based violence. So all of this is really upheld by the evidence, not just by all previous humanitarian crises that we've engaged in, but we're also seeing that data come through as expected for this crisis. I saw news today that in Bolivia, the domestic violence helplines have been flooded with calls from adolescent girls in particular, and are struggling to cope. We're also concerned by the increase in unpaid care work, disproportionate caregiving burdens. According to the ILO, the International Labour Organization, globally women perform 76% of total hours of unpaid care work, more than 3 times as much as men. And the existing gender roles of women and girls as primary caregivers, responsible for cleaning, cooking, caring for children, elders, the sick, will undoubtedly impact women and girls further across the globe. Of key concern to us in particular is the loss of education. Of total population of students enrolled, UNESCO estimates that over 89% are currently out of school because of COVID-19 closures. So that's 111 million of these girls who are living in the world's least developed countries, where getting an education is already a struggle, and we're concerned that rising dropout rates will disproportionately affect adolescent girls and roll back all the progress that we have made in this area over the last 20 years, particularly because girls are less likely to return to school once schools open. As we've already said, that might be because of early and unintended pregnancy, child marriage, or just based on their increased caregiving roles that they're expected to take on, especially if parents are sick or otherwise engaged. And when they do that, the remote learning programs that are available are less easy for them to access. So we are concerned about a lost generation here of children. Healthcare, I believe I have covered that the resources may be diverted elsewhere, and often due to the lower literacy or educational status of women and girls relative to men and boys, their access to critical health information is limited. And they have limited decision-making power on their health. Economic impacts. This pandemic will have devastating consequences for people's livelihoods, especially in fragile and crisis-affected contexts. As livelihoods collapse, household food security will deteriorate, resulting in a rise in hunger, malnutrition, especially for children. Economic stress is also highly likely to increase negative coping strategies, including child labor, child early and forced marriage, recruitment by armed forces and armed groups. According to the World Bank, women and girls are disproportionately represented in the informal economy, the self-employed, the cross-border work, and are therefore not covered by existing social protection measures where they do exist. We're also concerned about access to information. As I think I've covered, women and girls have limited access to accurate official information because of lower literacy levels, because of the digital gender divide, the ICT infrastructure, the gendered nature of public and communal spaces in many countries. And that's a problem we're seeking to address. And then also we're concerned about the lack of meaningful engagement with women and girls and their access to decision-making around this crisis. We as a sector are still not great at involving women and girls in the work that we do. So I'm going to quickly take you through what can we do about this. For Plan International, gender equality and our intersectional approach is core to everything that we do. This is not an exhaustive list. It might be exhausting, but it's not exhaustive. But it is some of the key standards that we are holding ourselves to, accountable to on this crisis. The first and of key importance, as I think I've demonstrated, is that a gender analysis is so important to understand the specific needs of women and girls, to understand the gender norms in any given context around household responsibilities, around protection, around the value and status position of girls, women, men and boys in that community, and to make sure that we're not increasing inequality and exclusion. We need to be collecting and analysing sex, age and disability disaggregated data. We need to be including targeted gender indicators in all our plans. We need to be assessing ourselves during design, implementation and evaluation. And we need to make sure that we're adopting interventions that recognise, reduce, redistribute the unpaid care and household responsibilities assigned to women and girls, and instead promote an equal share. And that goes for violence in the home as well. Critically, we need to continue to provide essential protection services remotely, and there's more guidance on how to do that I'll get to. We need to be analysing the specific protection risks, particularly around sexual and gender-based violence, as I mentioned earlier. We need to be meaningfully engaging with children and youth. We need to be closing the feedback loops. We need to be coordinating with the sector and sharing that data with the rest of the sector and with governments. And we need to consider different methods of communication, as I said, if literacy levels are different, if more inclusive methods for those who are deaf, if radio, ICT infrastructure, and so on needs to be considered. And not rocket science, but definitely, again, upheld by the evidence, the more gender balanced the field staff teams are, the more gender mainstreamed the projects are. And lastly, we really need to be tracking effects of this pandemic on girls and women, and we need to be sharing the lessons learned, as we have tried to do from previous responses as well. More information and practical guidance on how to do each one of these things is available on all of the above. For example, planned partner Men Engage have released new guidance on how to work with men and boys on encouraging equal share in the household, on reducing, limiting, ending violence in the home, and on how to do remote protection services. There's more guidance from the GBV AOR, the Area of Responsibility, and others, and I'd be happy to share any of that with anyone who is interested. And of course, this is a list of how to mainstream gender, and not, of course, all the programmatic approaches that we are also taking, such as continuing education programming through radio in some places, through WhatsApp, through online, and there's a lot more information that can be shared about that as well. So I think, in summary, understanding the gender dynamics of this crisis and of all crises is really critical to make sure that we're not doing further harm and that we're not increasing inequality. Thank you.
Thanks, Karen. Thanks very much for that. That was fascinating in terms of really drilling down to the gender impacts. So our final speaker today, last but not least, is Dr. Penny Vera-Sanso. She's a senior lecturer in development studies and social anthropology at Birkbeck, the University of London, where she works on the impact of liberalization on the global economy on livelihoods and gender and generational relations in low-income households. So most recently, she's focused on ageism and age discrimination and the role of older people's paid and unpaid work, particularly in India. So welcome, Penny. And thanks very much for joining us today.
Thank you very much for the invitation. I'll just try and share my screen. And yeah, and I hope this works. Oh dear. Hang on just a minute, I've got to expand this. Right, here we go. That's later. Okay. Right. So I'd just like to say, can you hear me? Anybody hear me?
Yep.
Okay, great. Thank you very much. So for this, I have drawn on my previous research, particularly the research that was done during the financial crisis of 2008. I've been working in Tamil Nadu since 1989, but I thought this was a moment to look and see how their responses were, people's responses in the slum settlements where I was working, and think about how it might affect now. And I've relied heavily on what's in the press, because there's very little else to work on from this distance. So in terms of COVID cases in India, India has a population of 1.35 billion. And in 2011, 8.6 were over 60. Tamil Nadu has a very large over 60 population, which was 2 years ago at 10%. But it actually, in India, there is at the moment a very low level of confirmed cases. That's matching Britain at the moment, of 20.5 case, only 652 deaths. Nearly 4,000 have cured, discharged, or have migrated, meaning they've lost track. And the lockdown has been going on about as long as ours, from the 25th of March, and there are hotspots. But interestingly, by comparison to Britain's case, hotspots are relatively low impact at the moment. So Dharavi, which is the big slum in Mumbai that featured in a Slumdog Millionaire, has only 168 cases, 11 deaths as of 3 days ago, yet they have 65% of Mumbai's population living in this massive slum. And what India is doing is it is creating containment zones around cases that they've identified. So I am saying that I'm relying on newspapers, so we don't know how accurate this is, but it's interesting that it's relatively slow at the moment. Now, Tamil Nadu, which is the area that I've worked in the most since 1989, has the 5th largest number of cases as a state. Now, Tamil Nadu has a massive population. I think it's about 77 million at the moment. And it has 1,500 cases and 1 death in Chennai, and 18 deaths over, Chennai is the capital of Tamil Nadu, and 18 deaths in Tamil Nadu overall. And so the first case that was identified, not of, just of a sickness, was on the 7th of March, and that was somebody who'd returned from Oman. And on the next case was the 18th of March, which is somebody who traveled down from Delhi back into Tamil Nadu. On the 19th of March, there was a case that had come from Ireland, and on the 21st from New Zealand. And then there were some tourists that had passed it on. But what's interesting here is that the disease is coming from outside. That means it's coming through a particular class groups. So we'll come back to that in a minute. So in Tamil Nadu, they have containment zones of 112 containment zones. And in these containment zones, nobody is allowed to move at all. Nobody can go in, nobody can go out. So the government takes food in there. It's very contained. Everybody's stuck inside their homes. But it's very severe. And everywhere else there's a lockdown, which means it's very similar to our situation, where you can go and get your necessities. Now, this is a graph that comes from the Ministry of Health and Family Welfare. And what's interesting about this is how low the new daily cases are, right? It's climbing very slowly. This is the buildup of current cases. Now,
Penny, we can't see your screen.
Pardon?
Are you sharing your screen?
Yes, is it not shared?
I'm not seeing it. Is anybody else seeing it?
I can't see it at the moment.
Oh, okay. Hang on just a minute.
Can't see it at the moment.
You can or can't?
I can't see it. Negative.
Oh, negative. Okay, hold on a moment. Hang on just a minute. I might have to escape from this. Sorry. Right. Oh, just a minute. This is a nuisance.
Can you see it at the bottom?
I can't get. I'm finding it difficult to get into the. Sorry. What a nuisance. Here we go.
Okay.
Move your cursor up, yes, and then you see everything at the bottom. Share screen.
Little green button saying shared screen.
No, so the thing is, it occupied my whole computer.
You should go down to the bottom and you can see, press on Zoom. Press on Zoom again at the bottom.
Oh dear.
Exact problem yesterday. But that's okay. I mean, do you feel comfortable going on? We can share your slides after.
Okay, let's do that, because this is going to take forever, which is a shame. But okay, so what I'll describe, and I've got all these lovely pictures, but sorry. So what's happening is basically it's hardly moving at all in terms of the increase in daily cases, but there is quite a lot in terms of what's built up over time. But there's actually very small numbers of cases. I just wondered if I could quit this. But anyway, okay, I'm sorry about this. I'm just going to have to go on. So what we've got is a situation that what's happening in India at the moment, it seems to me, is that we don't have many cases at the moment. And we have a situation where it may not get into poorer areas. Because of this, there's actually so much social segregation. People don't go to the same schools. There's a whole host of life is much more segregated. So it may actually not get in, right? Fingers crossed. But I mean, clearly it's got into the big slum in Mumbai. But it may not be quite what we expect. But whether it does that or not, I'm not saying it's not going to do it, but it would be interesting to see. It does have consequences, right? So the first thing, the consequence is that it is exacerbating social and political issues. So one particular thing is that Hindu nationalism, we know what was happening before COVID came, and so it's being used, COVID is being used to press sort of the Hindu nationalist agenda against Muslims, and it's also about, there is some stigmatization going on in the northeastern states about Chinese people and so on, or people who are Indians but seen as Chinese. And so there is this selective testing and reporting, and so this is pressing hard on the position of Muslims, and if it takes off, it will be, they will get even worse situation than they're already in. So that's one impact it'll have. There is, that we know there's been this massive internal migration, people leaving the cities to go back to where they were, and whether they take it with them, they may not actually take it with them. At first I thought, oh my God, it's going to really spread, but they may have been so socially isolated that they won't have got in contact, they wouldn't have been in contact with the class of people that come from Oman and so on, who brought it into the country. So that social segregation may actually work to have protected them, but they have walked home, they've been without food, they've taken their kids, so there's going to be a lot of damage at that score. They've been unpaid and so on. So what we're going to get is, and this I think is guaranteed, is excess deaths that are COVID related rather than COVID deaths itself. So we've got this 2020 lockdown, and this is what's happening in Chennai, for instance, at the moment. Chennai is interesting because there are so many opportunities for work for older people and for the urban poor, which is different from rural areas. So it makes an interesting case that, when there is availability for work and so on, that what happens. So at the moment with the lockdown, we've got essential shops that are open between 6 a.m. and 1 p.m. There is a lot of police brutality, and it's especially directed at young men trying to keep the lockdown. So they go for young men if they see them about. They go less often for others, particularly older women. So we've got factories that are open, but huge numbers of people have been laid off. All those who are less securely employed, which would be the majority. And people who are in personal services like domestic workers and drivers and so on, they've lost their work because nobody because the idea that contagion comes from the poor is a very dominant viewpoint, although in this case, contagion may be coming from the better off. But they've been cut from their work. But what we do have is, that's still continuing, we've got deliveries to homes, including work from some older women hawkers. We've got older women are still selling on the streets in the marketplace. We've got collections from homes, particularly, for instance, older men collecting from houses, collecting recycling and so on. So they're doing the social distancing. You know, these people are selling to people who are better off than themselves. We've got social distancing, and there is some space for some people to work, and quite often it's older people who are doing that work. Now, if we compare this to you know, what happened in 2008, the financial crisis, what was clear is that the poor are not a uniform group. And there were those who had waged work, as opposed, I did this analysis with Barbara Harris-White, and it's been published, where we compared wage workers to self-employed and retail sector to the service and manufacturing sector, and people aged over 60 to people aged under 60. And we found that people's economic circumstances position them differently in terms of the financial crisis, when actually there was this massive economic slowdown in India that cascaded down to the slums where people were not able to work. So, and then the other thing that was interesting about that was that people might be able to recover over the period and then couldn't sustain it as markets changed and so on. So it's not going to be a uniform response, and it's not going to affect everybody in the same way. But what was interesting in particular was that that older people did less well because of age discrimination and in pay and access to work and so on. And so, for instance, a lot of women, older women, are self-employed. But what was also interesting was that this age discrimination sets in at the age of about 46. So even people who are under 60 are not able, were not able to provide. And as a consequence, everybody in the family provides. It's not just people that we would consider to be prime or working age. And so we had what people were doing was, in the financial crisis, they were cutting back on food, cutting back down to 1 meal a day, often just rice, nothing else, for months, certainly several weeks, 2 months. And there was the removal of girls from school. There were delays on repairs and on health needs, meeting health needs. People took out a loan if they could get it, but most couldn't. Actually, the better off in the slums took out the loans, or those with pensions, not because the pensions were high, but at least it was a guarantee that there was some money to come in to pay off the loan, etc. People lost assets in the pawn shops because they couldn't get them back. They just had to forego them. They missed the repayments. And people were less able to rely on support from kin and other networks because they were suffering as much. And people were also unable to pay or collect rents, and a lot of people in the slums are landlords themselves. They divide their home up into two, get some money from one side, live in the other. So you know, there was a sort of cascading down from the financial crash, and it affects everybody. And this is the bit where I think the main impact will be on of COVID. It will be the certainty of an impact, okay? Whereas I'm not sure about exactly how, when, if, where COVID deaths will actually happen in low-income settlements in India. Okay, so in terms of government support, we have the government has given, they have, what is that called? Public distribution system. They have rations in India, but not everybody gets the ration. And in Tamil Nadu, 200,000 people get the ration, but there are 77 million people. A lot of people don't get the ration. Anyway, so the government has offered free rations for April for people who have the cards of the poorest, the ones that take the rice, but there's a lot of people who are not covered, and they gave them an extra 1,000 rupees. There's also been a one-off payment for 1,000 rupees to the unorganized sector welfare board members. But both of these just do not cover anywhere near the number of people that needs to be covered. And if you want to think about what does actually 1,000 rupees mean in 2020, in 2007, the average rents in Chennai was 600 to 1,250 rupees. And unfortunately, you can't see it, but there's a photograph of a woman outside a thatched hut, tiny small room, just a room, just an enclosed space, nothing, no services, nothing, and that was 600 rupees in 2007, which makes you realize that 1,000 rupees is actually a symbolic payment rather than an actual help. So the pensions are also at the moment 1,000 rupees for those who get it per month. So there's very little actual support for people. It's much more gestural. And so what the government is actually doing is they're insisting that these resources that they are providing go through government structures and not through NGOs, which is a typical way that support is given. And it is certainly suggested in India that the reason for this is that the government should be seen to doing something. So it's gestural politics rather than delivery. So
Penny, that's wonderful. We've only got one more minute. Can you?
Oh, okay, okay. So, all right. So, okay. So, thank you very much. Okay. So, in terms of the lockdown and the post-lockdown, we've got older people supporting families, and the main threat for them is that if the government starts regulating the wholesale fruit and vegetable markets, because that's one area, selling vegetables and fruit is one area that is very open, particularly to older women. And if they start licensing vendors, and if they start taking over, because they are doing that already with the containment areas, they're taking over the supplies. If that is happening, then women will be, their livelihoods will be cut. Similarly, if sons who are not able to get new jobs after the lockdown, they may well take over women's, particularly women's work, and men as well. So we've got the immediate impact of COVID and COVID-related deaths, which are, as we can all guess, impacts on health, assets, jobs, disruption of social and economic networks beyond the locality, because people do operate beyond it. But in the medium and the long term, what is really going to be significant for older people and also people in the slums, because they rely on their networks, they don't rely just on their family, is holes, people who go missing, right? People who died. Right. And that will, holes in those networks will narrow their the risk spreading that people do through their social networks, and also the if they lose access to work and so on, you'll get a reduced, and with these holes in these families and so on, you'll get reduced consumption. And then the last one is if the government takes over controls of the markets. So I think
so much for that, Penny. Thank you. That was really brilliant. I think that's a really good place to kind of end, because we've got a little bit of time for questions now.
Yes, of course.
I know there's I'm sure a lot of people would like to ask questions. Please use your raised hand on Zoom if you'd like to ask a question. Your raised hand button. Goon, do we have questions coming through from the audience?
So far, we don't have any. But if you want to ask a question, you can click the raise hand buttons in the participants box.
Okay, great, because I have a variety of questions, and the first one goes to Hannah. Hannah, thank you so much for talking about disability. And first, I'd like to thank all of our speakers. I mean, it was brilliant. And what you've done is you've shown us that you've shown this light down in areas that we wouldn't normally get to see. And you've given us there's really themes that cross this in terms of vulnerability and increasing vulnerability. And how are we going to stop this? But I have a question for Hannah, and that is, in the UK, we're identifying disabled people and highly vulnerable people, and there's a number of things. They're basically being sheltered for 3 months, and some people get delivered food boxes, and that isn't really available in most LMIC countries. So how do you see this playing out in terms of just the specific response in the UK that seems to have been very effective, and what lessons we can learn from that?
Well, I think there are two things that can be done in low middle income settings. The first is that people who are doing mainstream humanitarian actions need to be mindful of people with disabilities. So for instance, if there's a central distribution site or collection place for food, it may be difficult for people with disabilities to reach. So just to think about within that, if there are other compensations that can be made. And the second is that there are a number of programs that are going to be supported, which will specifically target people with disabilities. So in the first phase, it'll be identification of people with disabilities and vulnerable households, and then delivering, like there is in the UK, food relief, perhaps economic relief, and sanitation, hygiene products, so soap, in that same way. So I think usually with disability, and also in this settings, you'd advocate for a twin track approach, so to make sure that people with disabilities and older people are included in the mainstream, but also to specifically target them when that's possible. And also to say that we're certainly not perfect in the UK in many ways in our COVID response.
For sure. Okay, I have another question for Marcus and Karen on, the humanitarian sector is very used to this. We roll out the next crisis happens, and the same, in terms of plan and development in the NGO organizations. But what does this crisis do? Is it going to be the same old? Are we just ramping up to the same old? Or do you think COVID will push us into a new thinking in terms of humanitarian response?
Okay, shall I go first? Yes.
Yeah.
I think in terms of the consequences, the humanitarian consequences, I think it's hard to say right now whether it's the same or worse. It probably is fair to say that with all the information that we have right now, it is possible that it is going to affect certain contexts differently, yes. Now, with regards to the response, what we certainly see is that people like myself, well, yes, I sit in London and I'm not there where I probably should be, yes. So I think what we are going to see is a very, very strong emphasis on local humanitarian actors, not only civil society, but in particular also authorities, to really take an important role here. And what I hope is that we also see a better and stronger sense of complementarity between local, national, regional, and international actors. Whether they are state or non-state doesn't really matter. The sense of complementarity, I think, is going to be a big test. Whether actually humanitarian actors kind of get their act together and actually really work in complementarity much stronger than probably before. Yes, I wouldn't say it's the end of international humanitarian action, as I sometimes see. Yes, I wouldn't say so. Yes. These shifts have already happened over the past 10 years. Sometimes it's at work, sometimes it's having a shift towards more locally led humanitarian action. I see it, and I see this in our movement of Red Cross and Red Crescent societies, where you have got very strong national societies, some they are less strong. You've got the ICRC sometimes strong, you've got some federations sometimes strong. But this complementarity is really going to be a test for the case of complementarity. I think our response that we like to talk about. Case for complementarity. This really is going to test. It's just one point. There may be others. I'm sure there are others.
Thank you. And Karen, do you want to join in on that and talk about? I mean, because we know that you brought up a lot of really relevant issues around gender and how this will impact women. But we know the epidemiology is that more men are impacted than women. So do you see, and particularly with younger women are less impacted. So do you see any benefits that will come from women and girls due to this with COVID, or what's your perspective on that?
Yeah, I think it's a really interesting point. So I think we're seeing it's a slightly higher morbidity rate amongst men. I think it's about 51% men and 49% women. However, that data is really skewed towards Europe, China, and I think Americas, and that's just the data that's available. There really isn't enough data available. So I think, and the reasons that we know, the analysis of why that might be happening is related to, I think, men's higher rates of smoking, immunology and other things, which I definitely don't pretend to be an expert about. But I think for some of the reasons that I mentioned in the presentation, in some of the countries where we work, particularly sub-Saharan Africa, I think the opposite might be true for women and girls. We just don't have enough data yet. The crises there are sort of just starting. And I also think, like I tried to demonstrate, there's the primary impacts, which are morbidity, and the secondary impacts. And I might argue that maybe the secondary impacts are worse for women and girls than for men and boys so far.
Sorry, could I just pipe in on the epidemiology side about the death rate? Is actually there's the cases may be more or less 50-50, but the death rate is heavily skewed towards men at the moment. So it's more like 2/3 men to 1/3 women. And that's been shown consistently across European countries, very, very high. So although I'm very much on board with the secondary impacts being perhaps more profound and being more serious for women, I do think we need to be careful to say that actually the deaths are much more common among men.
But equally, that's a great point, because that increases the vulnerability of these households. And when you get female-headed households, and so, I mean, that is something that we need to kind of think about. We've got a question from the audience. Gun, can you relay that?
Yeah, sure. So this Sandra has a question. I'll unmute you if you want to ask your question.
Oh, yeah, thank you. Hi, I had a few questions for Hannah, actually. Thank you for your talk on highlighting the impact potentially of COVID on disability. But I was interested just to know about how you or your center, your colleagues are defining disability. So that was the first question. And then you also talked about the efforts here, particularly about supermarkets supporting those with disabilities using, having a special service for those who qualify as being on the vulnerable list. But there have been issues just even with defining or identifying this, because I'm finding, I know there's a lot in the media, but also personally, I have friends, colleagues, patients who have physical, particularly disabilities, visual impairment, paralysis, and they've been left out. They can't actually qualify if they go by the list. So what are your thoughts on that? Because, finding people actually struggling to do a food shop.
Yeah. So the lists are imperfect, and it's also not very transparent. And so there have been these documented cases where people believe that they need extra assistance and actually can't get onto those lists. And so this definition of disability is a bit complicated. So I'm an epidemiologist, and I could give you kind of very technical, this is in a study how you would go about defining disability, and it should cover the full range of impairments and people who have difficulty participating because of their impairment. But obviously in a humanitarian crisis, we don't have that luxury. And so we need to be a bit more pragmatic as to how people are defined. But it should be people, it should be regardless of age. So people who are older who have impairments, who may not see themselves as disabled, should be included. And it should be people who have visual, hearing, physical, communication, cognitive or mental health conditions that stops participation. And that can be quite a common universal definition. And then you have to work out how to implement that in a pragmatic way. So in the UK, that might be according to diagnoses, whereas if we were in a humanitarian setting and trying to find people, it might be more through word of mouth and through people reporting difficulties.
Okay.
But you've hit on the absolute biggest problem with disability, which is in terms of how do you actually define and measure and limit that scope.
Thank you.
I have a question for Penny. Is there another question from the audience, Goon?
Yeah, we have one from Ifyon Lee. Would you like to ask your questions? Hello, Ifyon Lee. Okay, the question was just sent to me. It's regarding Taiwan, or in the context of Taiwan, main mitigation measures like social distancing, work from home doesn't seem to fit for the IDP refugee camp settings. Is there any measure we currently have? I guess that one would be for Marcus.
Yes, sorry, yes, I'm trying to also get my video going, doesn't really matter, yes. Sorry, so the question, social distancing measures in IDP camps, that was the question, yes, and how is this done, yes?
Yes.
Well, honestly, it depends again, it depends on the camps, yes, but all these camps are people live in close confinement, yes. So I think social distancing can work, for example, that should the camps, but then again, that may not be the case, should camp residents, for example, be allowed to leave the camps, yes, depends on their condition, yes. Some of the camp residents may, for example, be able to leave the camp, go outside, yes, it's possible, but it's always very temporary. Even if you just go out of the camp, at one moment you have to come back. I think social distancing, I fear, I don't want to say it is impossible, yes, because I personally don't like the term impossible, because you can find ways for almost everything to come around, yes. But I think it is in camps, where in particular also actually the camps are actually going to be closed, for example, yes, for all kinds of reasons. It is almost impossible, yes. And that's why I think it is very important to actually try to prevent the virus actually from hitting those camps as much as possible, yes. And that is currently, as far as I understand, is that the way we operate and where we operate in those camps, this is where our focus is on, yes. Through better hygiene, to better communication. I think the communication with the camp population is then going to be very, very important to put those hygiene measures in place, yes. And indeed, if they are camp residents that all of a sudden do have these COVID-19 symptoms, but yes, depending on the context, they indeed can be sent to a hospital, yes, or to a healthcare center of some sort. Yes, may not even be a hospital, yes. But let's not be naive here. IDP camps, if something happens there, it can really, that's what my colleagues who are medics or health professionals tell me, this can be really have unfortunately a devastating effect. Yes, so we don't have to be naive here that prevention always works, of course not. Yes, it can be a first mitigating step, but it's worse may come. Yes, that unfortunately I think is the sad reality.
Thank you very much, Marcus. And I just have a very final quick question for Penny. Is there another final question from the audience, Goon? Because we're going to have to wrap up.
No, just go ahead.
Perfect. Okay, great. So Penny, my question to you is, thank you so much for bringing up this issue around kind of class and caste and these kinds of barriers of and what that looks like, sort of, and how that plays out in epidemiological terms. But one of the things that's happening, we have evidence from New York and from the Middle East, is domestic workers are incredibly vulnerable to this virus. And, we're hearing stories of the super rich going out on their yachts, and of course that yacht will be filled with people who are working on it. So what, if anything, is being done in India to protect these workers, and what's your kind of take on that kind of exposure?
Well, my understanding is that they've been turned out, they don't have work. And they're, the kind of people who have properties that would retain domestic workers. There are very few, but there are a lot of domestic workers who turn up for a couple of hours every day, 7 days a week or whatever, or 5 days or whatever. They've been cut. And I mean, in the media, there's an awful lot on, the experience of the middle class and they're all suffering because they're having to do their own housework. There is very little knowledge that we have about what's happening to in slum areas, because actually we know very little about slums. It's certainly through the media. At any point, every discussion about older people or poor people and so on is always taken from the middle class perspective. So everybody has, you know, almost everybody has domestic workers. They're hardly there. They've just cut them, so they've got no work. That's it.
Okay.
Right. And because it hadn't spread that much when they cut them, and actually, you know, what's interesting is the contagion is actually coming from the middle classes. It's not coming from the poor. So that may be helping poorer people in that respect, but everything else is really against them.
Okay, well, you know what? Thank you so much to our speakers today. Hannah, Marcus, Karen, and Penny, thank you for your time. And I'm sure everybody will join me in giving you a virtual clap for a really fascinating presentation and the discussion. Thanks so much. And please do, if you've got videos or slides to share, please send them to us and we'll put them out. All right?
Great.
So thanks very much.
Thank you.